So, guys, good afternoon. My name is Sotirios Kotoulas. I am a graduate of the Faculty of Child's Medicine in Pilsen, and I'd like to thank you all for coming and giving me this opportunity to help you with a topic that, at least in my years, was a bit of struggle for a lot of my colleagues as well as myself. I graduated last year. I'm now doing internal medicine specialty in the Army Hospital of Athens, and I aspire to be a cardiologist focused on interventional cardiology. Today, we're going to talk about electrocardiography in a very simplified and easy approach, but covering everything that you need from the second up until the 6th year of studies, giving a bit more emphasis at the start towards the younger students. So as we progress during the lecture, it is a fact that we'll go into a bit more depth and detail concerning ECG. What are our learning objectives? We decided to separate this lecture into 4 parts, starting with the basics of ECG, then following with supraventricular and ventricular arrhythmias, and finishing with heart blocks, myocardial infarctions, as well as some extra with metabolic abnormalities, as well as inflammatory conditions that will cause changes to the ECG. Now, no lecture is perfect, so I think your books are always your best friend. Personally, I use the only ECG book you will ever need as a basis for this lecture, but as a student, the ECG Made Easy as well as the ECG in Practice books were my best friend from the 3rd year onwards in order to revise ECG. However, this will not be enough. You need someone to do some extra explaining that the books cannot provide. So this lecture will do this partly, but also you can use a Stanford Medicine course. It's called a Strong Medicine AKG course. It's a series of 20 videos. It's about 3.5 hours, and it actually covers anything you need from the 2nd year of physiology to the state exam of internal medicine in the 6th year. So it is very highly recommended that you study this along with your literature. Now, let's begin. Do you have any questions? If you have any questions, good. Thank you for doing so, and I'll be happy to answer them either at the end of the lecture, this one, or after the break before we start the second part of today's lecture. Write them in the comments, we'll go through them and we'll try to solve them one by one, and I'll be happy if you'd also like to actually go through another session with questions, as well as some session with examples to see what we have taken from this lecture, what were the gains from this lecture, to see how it worked. Let me also mention, especially to the students of the younger years, that we will hand out certificates to anyone that takes part in both sessions. That means both Monday and Wednesday. And they will have the stamp of the faculty proving that you took part in this webinar. Now, if you don't have any questions, let's begin with part 1. Part 1 will be the basics of electrocardiography. Now, I will try to go through this very slow so we can get a grasp of what's going on. Let's start with something simple. What is an ECG? ECG or electrocardiography. Electrocardiography is a recording of the electrical events that occur in the heart as measured between 2 different points in the body. A standard ECG is composed of 12 leads. Those 12 leads will include 6 precordial chest leads, 3 standard and 3 augmented limb leads. And this might sound like something random, but we'll go through it later. Let's start with physiology. There are two principal things that are monitored during an ECG. The depolarization, which is the fundamental main electrical event of the heart that occurs spontaneously in the pacemaker cells of the heart. In others, it is initiated by the arrival of an electrical impulse that causes positively charged ions to cross the membrane, and this will be followed by repolarization. All those events are actually shown during a cardiac cycle, an ECG wave. Let's talk about anatomy then. So we said that an impulse starts. Where does it start? It starts on the sinoatrial node, which is found in the right atrium. And from there, it starts spreading through the atria intermodally towards the left atrium. So from the right to the left, carrying on towards the AV node, following to the bundle of His, and then leading to the right and left bundle branches of Tavara, finishing at the Purkinje fibers, which will activate the working muscle fibers. Now, I'm sure most of you know this from anatomy, but keep in mind that during the activation of the ventricles, the interventricular septum is activated first, while the lateral walls of the right and the left ventricle follow. It's worth mentioning that the basal area of the ventricles are activated last. So, we talked about firing. Let's talk about it. As you can see here, sinus node, the SA node, starts at 60 to 100 beats per minute, while at the same time suppressing the activity of the other pacemakers. Why? Because this is the principal pacemaker that works based on the principle of automaticity. What is automaticity? Automaticity is the ability of electrical impulses in the absence of exogenous irritants. What this basically means that it will do it on its own, even though no one provokes it to do so. There is the undoubted fact that not only the SA node can fire, but the AV node or the branches at the ventricles can also fire independently if something goes wrong. This is a case that we'll talk about, but at this point, make sure to note that the sinoatrial node fires at 60 to 100, the AV node if necessary at 40 to 60, while the ventricles fire at 35 to 40 beats per minute if necessary. Now, we said that a standard ECG is composed of 12 leads. What are the leads? A lead is a view of the voltage between 2 points in time. The voltage can be positive or negative. Positive will be looking upwards, negative will be looking downwards, and the leads will either be unipolar or bipolar, and we'll separate them accordingly. Now, let's talk about first about the bipolar or limb leads. The limb leads are bipolar. So, they are necessary to determine the heart electrical axis. So this will mean how the vector of the heart function would look like. We have lead 1, 2, and 3. And as you can see in the picture, we separate them from negative to positive part. Now, we have that Hoven triangle with the principle that you can see here, that the energy from the lead number 2 will be equal to the energy from the lead number 1 and number 3. And how will we measure that potential difference? In lead 1, the potential difference will be between the right arm and the left arm. In lead 2, will be between the right arm and the left leg, while in lead 3 will be the difference between the left arm and the left leg. This is very important to know, especially for physiology students, because this is something you need to understand in order to visualize how the leads can capture the ECG and the heart electrical movement. Now, you can see on the top, lead 1, lead 2, and lead 3. So it gives a different perspective on the same movement of the heart. On the bottom, we have the augmented leads that, as you see, use a different reference point to show the same event of the heart. So it's like taking the same picture for the same thing that is happening from multiple angles to make sure that everything is working in its finest capacity. So this is what we call the hex-axial reference system, lead 1, 2, and 3, along with augmented leads, AVR, AVL, and AVF. Unipolar leads, we talked about the bipolar leads, let's talk about the unipolar leads. The unipolar leads are the ones that measure the difference from the central terminal of Wilson, which you can see in the center here of the picture, and it is composed by leads V1 to V6. I think it's rather simple. We will talk about how we place those leads in just a few seconds. Also, don't forget to mention the AVR, AVF, and AVL, the augmented leads, that actually gain greater potentials, showing us the deeper insight into the function of the heart. Now, we said that augmented leads are derived from the same 3 electrodes, but they use the Goldberger central terminal as their negative pole. You saw that in the leads 1, 2, and 3, we use on the one side the negative pole, on the other side the positive. This use the Goldberger central terminal as their negative pole and measure their activity accordingly. Now, we have to talk about how we place the limb leads, the chest leads. What I do in practice is use the rule of the traffic light. So we use green, yellow, and red in that order, counterclockwise. In the left leg, we will use the green. On top of green, on the traffic light is the yellow, and on top of that is the red. The black part is on the right lower limb, and it's the part that is actually the one that's always left out. So again, go with me. Left leg will be green, left arm will be yellow, and right arm will be red. Now, the most important part, and you really need to get this stroke well in order to have a perfect view to avoid any misunderstandings. Now, 6 chest leads, V1 to V6, V1, fourth intercostal space to the right of the sternum, V2, fourth intercostal space to the left of the sternum, V3, directly the line between V2 and V4. V5, level 4 at the anterior axillary line. This is extremely, extremely, extremely important for 3rd and 4th year students. Guys, keep in mind, you need to know how to place an ECG and how to perform one. And then in some cases, you can have a V4R, which is in the 5th intercostal right midclavicular line. Keep this picture in your mind. You need to be able to form and make this ECG on your own. Now, I spoke a lot about theory, but this is how it actually looks in practice. You can see here the leads 1, 2, and 3 and how they work, how the augmented leads work. We said that those are bipolar, those are unipolar, and you have V1 to V6 using the central terminal of Wilson. So as you see, the central point differs in each and every case. It's not the same. Now, let's go through what an ECG will be like. Waves. I think it's pretty self-explanatory. It's a wave. A segment will be a line that connects 2 waves, and keep this in mind because there are multiple segments or multiple intervals that you can actually see in an ECG. Let's go through them one by one. This is a typical ECG. This represents a whole cardiac cycle, so event of a depolarization that begins in the atria and continues to the ventricles, and the repolarization that occurs after it. So, how does it begin? We said that in the essay note, the P wave will represent the atrial depolarization, and it will be the first part that occurs in a cardiac cycle. It is followed by the PR interval, which is the part that you can see here, which demonstrates the start of atrial depolarization to the start of the ventricular depolarization, up to this blue point, fine line right here. This PR interval is composed of a P wave and the line that connects it up until the beginning of the QRS. The QRS does not belong to the PR interval. What do we see next? We see the QRS complex. The QRS complex is indicative of ventricular depolarization. So this is the event that occurs in the ventricle after the depolarization has occurred already in the atria. Then let's talk about the J point. The J point is the point where the QRS segment, the QRS ends and the ST segment starts. The ST segment is an isoelectric line usually where the ventricles are depolarized and we start the repolarization. This is from the end of the QRS, so the J point, up until the beginning of the T wave. The T wave. The T wave is an indication of the ventricular repolarization. As you can see, it's more gradual at the start and then it calms down. Last but not least, it's very important to talk about the QT interval, which will be the ventricular depolarization and the mechanical contraction of the ventricles, as well as the ventricles repolarizing. Is this clear? Is there someone that wants to ask something? I'm here to listen if you have any questions about this. This is a very important slide, and you need to understand how this works. This is everything we will talk about today is based on the understanding of how this functions. Okay, if anything, we'll go through it later. So, again, the P wave. The P wave is the green wave right here. and it's an indication of the atrial depolarization. It has to be less than 0.1 seconds of duration. That will be 3 tiny squares on an ECG paper, and the height will be less than 2.5 millimeters. The P wave is best seen in leads 1 and 2, and it's positive necessarily for sinus rhythm. We will talk about this later. Very good to see the P wave in lead 2. This is very important, as well as leads V1. Now, for older students, abnormalities of the P wave. Let's talk about P pulmonale and P mitrale. P pulmonale is the presence of a tall and peaked wave. You can see that it should be less than 2.5, and this is more than 3 over here. And it's an indication of the right atrial enlargement. So that means that the right atrium is extended for some reason. This can be with problems with the lungs or either with the pulmonary valve. Now, P mitrale, and I have M here in red because it's a biphasic. It looks like an M. So this is an indication of enlarged chambers with enlarged and longer P wave. And the possibility that the P wave might not be present in either dogs, but we will go through this later. And lastly, we can have the inversion. What does that mean? This means that the atria are depolarized in an unusual direction, and the pacemaker is not sinus. And this can actually make sense because you try to capture this picture from multiple sides. If you see in lead 2 that the picture is not taken as it should, you will have a different result. That means that something is going wrong. That means that something is not functioning as it should. Now, let's talk about the PR interval. This is a very important part of the ECG. The PR interval starts at the start of the P wave until the start of the QRS, and it represents the atrial depolarization and the delay in the AV junction. And now you ask, why do we care about the delay in the AV junction? Because this delay will allow time for the atria to contract before the ventricles. And this makes sense because you cannot have atria and the ventricles contract at the same time. You need the atria to depolarize and contract first in order for the blood to pass from the atria to the ventricles and from the left ventricle to the rest of the body in the periphery. Okay, so the normal QRS time will be from 0.12 to 0.2 seconds. So in the ECG paper, this will be from 3 to 5 squares. Now, this will be a big slide, but just keep in mind that for the basics, you need everything that is in color. The QRS complex is composed of 3 parts. So we have the PR interval, and then we start with the Q. Every deflection that goes downwards, that's after the PR, is termed a Q. An R wave is any positive deflection of the QRS that is after a Q. And last but not least, a negative deflection after an R wave is termed an S, so QRS. It is true that there are many variations of this complex in many diseases as well as many pathological conditions. As you can see here, the variability depends, but the rules always remain the same. You will be able, if you understand those basic rules, to name any type of QRS that you see, even if that means it is a QS or an RS-R. Keep in mind, after the PR interval, which finishes here, you have a downward deflection. If it's after a PR interval, it's a Q, even if it has no R wave before that. So, simply, the variations are many, but you need to be able to understand that some of them are pathological, some are physiological, but the most mainstream type of QRS that you will see on the ECGs, especially the physiological ones, will be this form: a first wave that is negative, followed by a large positive wave, and finally a small negative wave. Keep in mind that a QRS should never exceed 110 millimeters, 3 little squares. This means that there is a problem in the ventricles. QRS is representative of the ventricle action, so it should work properly and have the proper duration. Now, as we said before, a T wave. A T wave is usually asymmetrical. As I told you before, the first half is more gradual than the second part. and its orientation should actually follow the orientation of the QRS. Keep in mind that it's part of the ventricular repolarization, and it's usually altered by electrolyte disturbances such as potassium and calcium, and it's also affected by infarction events. Now, the ST segment. The ST segment is a part that where the QRS terminates at the J point, and it is between the J point and the T wave. Also equally important in myocardial infarction as well as pericarditis, and we will go through this at later lectures. But keep in mind that the principal mainstay and presentation of an MI is the ST elevation. So the ST segment is very important to remember. We said it's from the J point up until the initiation of the T wave. Keep in mind, those are the 10 ECG. I know that they're full right now, but I'm pretty sure that if you lecture once or twice, you will be able to reproduce those rules on your own without having to think about it. The PR interval should be 120 to 200 milliseconds. The P wave has to be upright in the following leads, 1, 2, and V2 to V6, but keep in mind that lead 2 is the most important lead to have the P wave positive. The width of the QRS should not exceed 110 milliseconds, and it should be dominantly upright in leads 1 and 2. The QRS and the T wave have to be in the same direction, so if one is positive, the other one should be positive, and vice versa. Very important, all the waves should be negative in the lead AVR. Professors ask this, and they ask it all the time. Keep in mind that all waves can be negative in the lead AVR, and that is not necessarily pathological. If you see a P wave that is negative in the lead AVR, that does not mean that the patient has a rhythm abnormality. It's just because the presentation of the heart in that lead is formed that way. Now, RNS wave rules, they must grow from V1 to V4. The ST segment should start isoelectric. And remember, why do we care? Because this will be a sign of myocardial infarction, while the T wave should be upright in leads 1, 2, and V2 to V6. So, take home notes from these 10 rules. The AVR leads can be negative, and keep this in mind. The QRS and the T wave should have the same direction in limb leads, and the width of the QRS should not exceed 110 milliseconds. Now, for the younger students, let's take a look at an ECG, and I'd like someone to tell me what they see here. Do they see anything pathological? Keep in mind, we need to see the 10 rules, and as you can see here in the AVR part, you can see the waves are negative, but that is not pathological. This can occur because it's the lead AVR. Now, we can see a P wave here, a QRS, and a T wave with an isoelectric line in the ST segment, followed by the next cardiac cycle. This whole package is called the cardiac cycle. Okay, so this ECG actually follows all the 10 rules, and there are no issues. Actually, it's pretty normal. And I'm pretty sure at the end of this lecture, you will be able to understand why. So let's start with the basics, and this is important for clinical practice. What you need for an ECG to be correct, you need the name of the patient, the date, and readings from the precordial as well as the chest leads. For older patients, for older students, keep in mind that the blood pressure measurement is also a good idea to have written there. Why? Because it will indicate that no matter how the atria and the ventricles work, they actually manage to pump blood into the periphery. It doesn't matter if you have an all normal ECG, if the patient's blood pressure is between 7 to 5. Why? Because that means the heart is not working properly. So an ECG is actually nonsense. Now, there are 5 mainstays of how to read a basic ECG, and if you master those, you can find pretty much any abnormality that you can find in a piece of paper that you have, even if that's an exam, or your clinical practice. I will start with the part that is not one of those 5, and it's to never trust the computer. It is true that in the hospital nowadays, we have computed ECG machines that actually manage to give you a diagnosis of what could possibly be wrong. But that's actually not correct. It's proven that 1 out of 3 times, even though it finds something pathological, there is nothing wrong in the ECG. So keep in mind, heart action, rhythm, frequency, heart axis, and individual waveforms are the 5 steps you need to see in order to distinguish any problems that might occur in the ECG, from something mainstay like atrial fibrillation up to pericarditis, myocardial infarction, anything you can read if you follow those 5 rules. What can you trust from the computer? The heart rate measurement actually is correct 99.9% of the times, and this is something that is usually trustworthy. But we will learn how to calculate it, because on the off chance that it doesn't work, you have a machine that doesn't calculate it, you need to be able to do so. And if usually the machine says that the ECG is normal, the possibility of it actually being normal is extremely high. The problem is that it gives false negative results. So that means falsely pathological results. Let's go one by one then. And I'll start slowing down now, because you need to monitor and understand what we're saying. Let's talk about action. The action can be regular or regular. How do we see this? We will now go through, measure the distance from here to here to here. This period here is called an R to R interval. Why R to R? Because R is actually the part of the QRS. This is the part of the QRS, the R wave. And you can see that the amount of boxes between here and here is stable. And I'm pretty sure the same will account for here and here. If this distance is the same everywhere, then the action is regular. Okay, so this means that it's very easy to calculate the heart rate without requiring the use of the machine. However, let's go about here where we have an unstable RR interval. And how do you know that? Because it's written, but also because if you measure the distance of boxes from here and here, this obviously period here and here are unequal. So that means that the action here is irregular. Now, let's go. I think this is very simple to understand. Regular action means that our interval is stable, and irregular means that this is unstable. And why do we care? How do we? Okay, give me a second. Okay, so let's go through this again together. We said that one of them is regular. What will this mean? Regular will mean that the distance from R to R will actually be stable. So in those two, which do you think is actually the stable one? Can someone write me in the chat which one is the stable one? Which one has a R to R interval that is the same? Will it be the pink ECG? Yes, yes, you're both right. It is actually the left one. Why? The distance is the same. So that means that the action is regular. Okay, keep this in mind, because now we need to calculate the frequency based on the regularity. Okay, so keep in mind which one was regular and which one was not. Part 2 out of the 5 steps was the rhythm. The rhythm, especially for younger students, will be separated into sinus and non-sinus. Okay, sinus will mean that it starts from the SA node and everything functions as it should, while non-sinus, as we said before, means that there is firing from somewhere else. The requirement for sinus rhythm is actually pretty simple, and it's one of the 10 ECG steps. What is it? Is that the P wave should be positive, as you can see right here, and before every single QRS. All those are P waves, and they are actually before every single QRS. So this means that since they're positive and before a QRS, they have sinus rhythm. And what also should be mentioned is that the non-sinus rhythm can either have a P wave present or not. I'm sorry, but I can't find my cursor. Okay, so erase it. Again, we want a sinus and non-sinus ECG. Let's see. Sinus, we said, in order to have sinus, you need a positive P wave, which will be before a QRS. Keep in mind that lead 2 is the principal lead where you can actually see the circuiting. Can someone type me in the chat which one is sinus and which one isn't? Yes, you're right. The right one is sinus, and I hope you keep note because it's very simple, and the principle will always be the same. The first question always seen will asked by the teachers actually will be, is it sinus? Is it not sinus? It's sinus if there is a P wave that is present before a QRS and it's positive, and lead 2 will be the principal lead that you will have to be able to see this. Now, frequency. Frequency, is it fast, is it slow, or is it normal? We said that the SA node fires at the rate of 60 to 100, so let's say 60 to 90, okay? In those 3 ECG strips, you can see that the amount of boxes between the QRS complexes differs a lot. Actually, from 2, 4, 6 here, to 4 here, to 2 here. 2 big boxes that contain 5 smaller ones. So as you can tell, the heart rate is of course different. Keep in mind that the way we will measure this heart rate from now on will always require for you to use a paper that is counting at 25 millimeters per second. It's actually not uncommon in clinical practice for mistakes to be made where they take patients for tachycardic because the paper was not counting at 25 millimeters per second. Don't be deceived by what you see, okay? Sorry. So let's count the rules of ECG. You can see 3 steps right here. Can you guess which one is normocardic, which one is tachycardic, and which one is bradycardic? Let's think why. I'm actually stuck. Can you actually guys hear me?
Yes, we can hear you.
I can't actually see my cursor. Okay. Let's go. Great. Let's go. how do we measure the frequency in regular heart rhythm? Okay, so if it's regular, we said that the R to R interval, which will be the interval from this one to this one, and from this one to this one, will be the same, okay? And we will use the so-called 300 rule. We will use the 300 divided by the amount of big boxes, such as this one and this one, that are in between the two QRSs. So here there is 1, 2, 3, around 4 big boxes. So if you have regular rhythm, which is the case here, because this is about the same to here, and to here, we will use the 300 divided by 4 rule. This will make your life a lot simpler. Why? Because 300 divided by 4 will be 75. So one big box between the two will be 300. 2 will be 150, 3 will be 100. And this way, you will know this mechanically, and you will actually get work done a lot faster. Okay? So if we go back, we will see 300 divided by 1, it's regular. 4 big boxes, divide 300 by 4, that's 75. So there goes your heart rate. You got it. Excellent. So let's talk about the irregular heart rhythm, shall we? This is a bit of a tougher one, but I think you can get the hang of it. We need the heart rate measured in beats per minute. A minute is 60 seconds, okay? So you can see here that we have 1 small box, and 5 small boxes constitute the bigger box, the ones that we use in the 300 rule, okay? Okay. When you have an irregular heart rhythm, that means that the distance between R to R is not stable. So you cannot use the 300 rule, unfortunately. So how do we do it? There are 2 ways to do this. The first one will be to actually use 5 seconds of time on an ECG, which will be how many? It will be 5 small squares will be 0.2 seconds, 5 large squares. So here, all those squares here represent 1 second. So you need 5 seconds. So 5 times 5 will be 25 large squares. If you measure the amount of QRSs, then you will actually be able to multiply that, okay? If you have 5 seconds, you multiply it by 12 to have 60 seconds of time and see how many beats you have in that period of time. Let's go through this so it makes a bit more sense, shall we? Okay, so let's calculate the heart rhythm on the left, and I need you guys to be vocal in the chat here. Okay, good. Let's go to A. Can someone tell me the heart rate right here? If they want, I can open the microphone and they can go through this with me if they'd like the help. Someone? Anyone? Any volunteers? Nobody? Okay, you are actually correct. Okay. But actually, you need to explain to me why. Is this regular or irregular rhythm? It is 50, yes, because it's regular. So you can use actually the 300 rule to calculate the amount, okay? Good. Let's go to B now. Is it regular or irregular? Regular, and yes, Anton, you're right. It's also regular, yes. And the rate is 150. Why? Because there are 2 big boxes in between the 2 QRSs. Using the 300 rule, as you can see, it's very simple, no? And last but not least, let's talk about C. Is the C regular or irregular? That is irregular, that's correct. And yes, let's go through it and explain why, shall we? Okay, so as you can see here, it's irregular. So we need 5 seconds of time, and you need to in those 5 seconds of time to multiply it by 12 to know the amount of beats occurring in 1 minute, okay? So 25 boxes, 1, 2, Actually, it's right about here. So we have 18 QRS complexes in 5 seconds. So if you multiply that by 12, you have 216. Is everyone understanding how this works? Can anyone who doesn't understand it, I'd like them to write it in the comments, and I will gladly help them understand how this works. If anyone didn't understand, can you please write in the comments now before I change my slide? No, everyone got it? Again, okay, so Mona. Here, is the rhythm regular or irregular? So what does that mean? Are the amounts of two big boxes between two QRSs the same or different? Is it regular or irregular? Can you answer that for me, please? Are you there? It is irregular. So this means that we cannot use the 300 rule in order to calculate the heart rate. Is that correct? It's correct. Okay. So what do we need to see? A minute has 60 seconds, okay? And we need to know the amount of times that the heart is firing in those 60 seconds. The problem is because the ECG captures a very small amount of time, if you need 60 seconds of heart activity to calculate it, it will be impossible to do so because you'll need 3 meters of paper. So what do? We take a snapshot of those 60 seconds at around 5 seconds, okay? Are you with me? So 5 seconds will require 25 of those boxes here. Let me annotate. 25 boxes like those right here. And what you need to do is you need to measure the amount of those QRS complexes that are occurring in 25 seconds, in 5 seconds. That is 25 boxes right here. Okay? If you know what happens in 5 seconds and you multiply that by 12, you have the number of times that this occurs in 1 minute. Does this make sense? Let me know, please, in the chat. Please. The 25 speed of paper is necessary for the 300 rule, of course. Because then, of course, we will use 150 as a rule for 50 millimeters per second. And you can see it's doubling down. The relationship is oppositely, right? Good. Thank you, Tobias. So I think we're okay to proceed. Good. Now, keep this in mind. You will never talk to an exam for an ECG without first determining the underlying rate and the rhythm. So the first 3 steps are pivotal in order to understand how an ECG will be presented to your teacher, to your professor, or to anyone in your clinical practice. And I hope that everything we said right now makes sense because there's nothing more you need. This is enough to explain the basic things that occur during an ECG. Let's go. Now, a bit more fulfilling and a bit more challenging will be the determination of the heart axis. Now, in order to calculate the heart axis, it will be the position of the heart and how it fires. So as you can see here, this vector right here will be the heart, okay? Does this make sense? I hope it makes sense, because this will be where the apex of the heart will be, okay? This is very weird. So is this, but this is indicative of any pathological conditions. So keep in mind that we take a look at 2 leads, lead 1 and lead AVF, okay? And what we take into account in those 2 leads is if the QRS is positive. So if it looks upwards, if the highest part of the QRS is looking upwards in lead 1 and lead AVF, the axis is normal from 0 to 90 degrees, okay? So it fires downwards. This is the normal position of the heart, okay? Now, let's go here. Lead 1 and lead AVF, positive in lead 1, like here, and AVF, it will be negative. So it will be looking downwards. The axis will look this way. I know this is hard, but it is a fact that you will actually have to memorize this. You will need to know what it means for the axis to be in certain position. So LAD, okay, will mean left axis deviation. So that means that the heart is shifted to the left for you. I think that's for you, right? So does this make sense? To the right or the left? Does everyone understand this? You need to actually know this table right here. In order to understand which way the heart is facing, you need to know this table. You look at lead 1 and AVF, and you look at the positivity of the QRS, okay? This is something very extreme, and I hope you're not in a position to have to deal with it, okay? Does everyone understand this? Can someone write that doesn't understand this, how it works? Okay, one time. So I guess everyone of you got it. Part one. I guess you will need a break because that was a lot of information dumped at once. Let's agree to 5 minutes break. Is everyone okay with 5 minutes break? And do you want to do questions now or later? Free to anything. 5 minutes break. So let's say that we carry on at 5 to 8, if everyone's okay with that. Okay? Because supraventricular arrhythmias will also be a handful. Okay? Be back in 5. So, is everyone still here? Yep. Do you think you want to start second part? Okay. Ready when you are. Let's do it. Good. So, the heart will be separated into 2 parts, the supraventricular part and the ventricular part. I think this is very self-explanatory. We'll now start with supraventricular arrhythmias because actually they contain the most common arrhythmias that you'll have to see, and they're actually the simplest one. So you know that the with the sinus arrhythmia is extremely necessary for your progress during physiology studies, and the rest will be necessary for pathophysiology, propedeutics of internal medicine, as well as internal medicine in the end, because keep in mind that the internal state exam will actually have an ECG part, which is necessary in order to get a passing mark, okay? So let's start with supraventricular arrhythmias, and we will talk about arrhythmias that are originating above the bundle of His. Remember the shape with the bundle of His and how the conductive system of the heart works. You must be familiar with the anatomy of the conductive system of the heart, okay? So, okay. So, we spoke about arrhythmias, but let's talk about what an arrhythmia is, right? So, an arrhythmia is a disturbance in the initiation of the conduction of the cardiac impulses, which means nothing, okay? An arrhythmia is when the heartbeat doesn't go according to plan. It's very simple. It's just that, okay? Now, this is how complex it can be, but we will make sure to simplify this a lot more than it looks like in this chart, okay? But I'm pretty sure that even now you can actually get up to this part, which is not such a small deal considering we only started like 50 minutes ago, okay? So we said that there are 2 types of arrhythmias, supraventricular and ventricular arrhythmias. Today, we will focus on ventricular and supraventricular arrhythmias right here. So they are above the bundle of His, good, and the QRS is narrow. And this actually should make sense to you because a supraventricular arrhythmia means that something is occurring in the atria. So the QRS, which represents the movement of the ventricles and how they work, should not be affected. There is a problem with the impulse at the atria, okay? Is this clear? Yeah, I can see. Give me a second. Okay, so supraventricular arrhythmias will be above the bundle of His, and they will have a narrow QRS. Good. Where is the cursor? God knows where. Good. Where is it? Let's go to the next slide and then we'll over this because this is not working as it should. Good. So let's simplify the stuff a bit, right? Okay. So the supraventricular arrhythmias work as following, okay? We will talk about sinus arrhythmia. So that would mean that there are problems that occur in the SA node, okay? Problems that occur in the atria and junctional arrhythmias. This is quite tough and mostly for 6-year students, okay? So keep this in mind, okay? And we'll go from there. Let's talk about sinus arrhythmia then, okay? First one, we will call this respiratory arrhythmia. This is the simplest arrhythmia you can face in an exam. And actually, I'm mentioning this exam because it's very rare to take note in clinical practice. But I know for a fact that in pathophysiology exam, this is one of the common ECGs that occurred. I know so because me and my colleagues had it, okay? So what can you see in a sinus arrhythmia? Okay, we will see as very minor accelerations of the heart frequency with inspiration and deceleration of the heart frequency with expiration, okay? So we said that it is a sinus arrhythmia. What does that mean? Okay, sinus will mean that there is a P wave that is positive and present before every QRS, okay? So sinus. Why? Because there are tiny differences in this and this distance right here that occur with inspiration and expiration. So if you do this, there will be a bigger heart frequency than when you expire, okay? And this is very minor. So this is in vegetative, in kids, and during sleep. I want the third-year students to take note that if you, in the pathophysiology exam, in the practical part, you have an ECG that looks completely normal, take a second look because it is probably a respiratory arrhythmia, okay? No biggie. Let's go. Sinus bradycardia. We spoke about this, okay? So bradycardia means slow in Greek, bradys, it means slow, okay? And it will be sinus. So sinus will mean, and I will keep saying this and repeat it again and again until you're familiar with the term sinus. Sinus means that there is a positive P wave before the QRS in lead 2, which is the principal one that we look for when we look for sinus. And it's present before every QRS wave. So P wave that is positive before QRS and so on and so forth. But as you can see, the heart rate here is very slow. Why? Because from R to R, the distance between the boxes is extremely big. Can anyone in the comments actually explain to me how much the heart rate is here? Okay, can someone write to me how much the heart rate is in this ECG? I'm waiting, okay? Will not go on until we know. Anyone? Yes, yes, yes. That means it's working. Excellent. 50. So bradycardia, slow, heart rate under 60, and sinus. The SA node is firing at a very small rate pace, okay? Let's go to the opposite part now. Sinus tachycardia. Tachy is Greek for fast, and the heart rate is more than 90. Now, this is a rather difficult ECG strip. Why? Because you can see the P wave here and here and here and here and here and so on and so forth. We will stick here to lead 2. And can actually someone tell me what is the heart rate in this ECG? Yes, this is approximate and this is correct. It's 150. Why? Two big boxes, and this is a sinus rhythm. It's regular. So we use the rule of 300 divided by 2. That's 150. Excellent. Now, this is more complicated and more directed towards clinical practice. So I'd like the older students in the audience to take care of this, please. This is an internal medicine exam strip, okay? As you can see here, the ventricles are firing and the atria are firing right here. So P wave, QRS, okay? And here there is a pause, okay? We call this pause a systole. Why? Because there is no contraction of the heart occurring. It's quite simple. But then it starts firing again. So this means that there is a sinus arrest. Sinus, why? P wave before every QRS, it's hidden here. P wave, P wave, P wave, P wave here, P wave here, before every QRS, and then arrest. Why? Because then it stops, asystole. It doesn't fire, even though before it was firing properly, okay? So, I hope this makes sense. Does everyone have any question? Does everyone understand this? Anyone have a problem with this? If you just pay attention and keep notes right now, I think by reading these notes, you will be able to familiarize yourself with ECG relatively fast. So, okay. 6 sinus syndrome, okay? So, this is exchange of tachycardia and bradycardia at the same time while maintaining sinus rhythm. Sinus rhythm, positive P wave before every QRS. I'll keep saying this until I make sure you all know it, okay? 6 sinus, why? Because you can see, can someone tell me what the rate is right here, where I will draw, okay? The rate here, what is the rate here in this segment? And what the rate is here. See, this is an irregular ECG with 2 separate regular parts, okay? This is regular, and this is regular, but separately, okay? So this makes sense. Can anyone tell me what the heart rate is on the first strip of the ECG, on the first part, okay? Can someone tell me? Anyone? Around 200, that is actually correct. Yes, yes. On the other part. Actually, 250 is a more, yes. Yes. Monica, around 200, but not exactly. Yeah, around 100, but not exactly. Why? Let's measure. It's a bit more. Yeah. It's between 175. Why? Because there are a bit more than 3 boxes, right? Yeah, exactly. 85, Hannah, sounds more like the correct amount, okay? Does this make sense? Does everyone get it? So, we see that we have alternating tachycardia and bradycardia. That means that something is not firing rapidly, and this is very tiring for the patient and the patient's heart at the same time, okay? I think this makes sense. It's tiring because imagine the heart cannot work as a pump properly if you like. Imagine doing the bike doing this, then doing very slow. It's nonsense. You cannot actually have a proper output if it works like this, no? Okay. So, everyone is familiar now with the concept of sinus rhythm. I will take it. Okay, everyone's familiar with the sinus concepts, okay? So, take-home messages. I cannot repeat this enough, okay? Sinus means that there is a positive P wave before every single QRS, okay? Keep an eye on the heart rate for any minor changes with breathing, especially for students undergoing pathophysiology exam, okay? This is it. This is all about sinus arrhythmias. It's that simple. And second year students, this is actually enough for you, okay? Basics of ECG with sinus arrhythmias are fine enough for you to pass the practical part as well as the theoretical part of the exam if you have the question about ECG to talk about in the oral. And I think it's pretty self-explanatory. Sinus, positive P wave before every QRS. For everyone else, the best part starts now, actually, okay? Atrial arrhythmias. Oh, and of course, we would start with atrial fibrillation. Why, you ask? Because atrial fibrillation is the most common sustained cardiac rhythm disorder. There is a rapid atrial activity, and how will this present? Multiple P waves. Why? Because a P wave represents the function of the atria firing at an unbelievably big rate of 400 to 600 beats per minute. So, as you can tell, this will look like a mess, right? Okay, but the QRS complexes will look fine. Why? Because the QRS complexes represent the function of the ventricles, and the problem is not at the ventricles, it's at the atria. Hence, it's called atrial fibrillation, okay? And now you ask, why do we care? And why? Because why do we care that the P waves are so all over the place and the QRSs are fine? Because the AV node acts like a traffic controller, and it only allows a part of the impulses from the SA node through to the ventricles. This is why, because in case that all the impulses pass from the atria to the ventricles, we will have a hemodynamic collapse because the heart won't be able to function as a pump. If you do this, what's the ability to pass blood to the periphery? Okay, it makes very sense. What is very important in this slide, and I want everyone to actually take good notice, is that this is an irregular rhythm. Now you say, what does it mean? It means that action is irregular and the morphology of the P waves is equally irregular. And please, I would like everyone to take good note of this slide, because to have atrial fibrillation, this is something you will see in your exams and your clinical practice all the time. And it is very important to understand why. So, can we see distinct P waves? No, because there's this mess. Here, let's go. We said P waves that leads to. This is a mess. These multiple P waves or what? No, it's not a proper P wave preceding every single QRS, right? This is not the case. There are no proper P waves. There are many of them. Decline the beats. When a heart cycle finishes, there should be a small systolic decline before the next part begins. But this is not the case here. You see that there is constant jittering of the line before another QRS. The QRSs are actually fine. They're narrow, tall, no biggie. But the intervals from here to here are irregular. So this is an irregular rhythm. Keep in mind, you need to understand all these parts. And I will not stop with this slide until everyone understands this. Does anyone have a question about atrial fibrillation? What does it mean? Is that the atria fibrillate, they don't function correctly, they move a lot faster than the ventricles, they fire non-stop, and only a handful of those multiple impulses go from the atria to the ventricles, where we will have normal QRSs, because even though they occur at random times, so it is irregular, okay, the AV node tries to save the ventricles from the fibrillation that occurs in the atria. Does everyone understand this? Those boxes here are necessary parts you need to explain if you have an ECG strip with atrial fibrillation on your exams. Does everyone understand this? Just write yes, it's okay, good. Yes, yes, great, good. Now, this is also a thing. This occurs a lot. So, in clinical practice, if you're not sure if the patient is fibrillating or if an ECG machine is broken, just perform it again, because some colleagues might say, oh my God, the patient is fibrillating, but there is no clinical evidence to support that. Atrial fibrillating patients will have a pulse that is weird. It will feel different every second. And yet you'll go to the patient like, they call like, oh, the patient is fibrillating, I don't know how to make an ECG. And you're like, okay, let's just take another one and see how it goes. And then when you take the other one and you see those criteria here again, then you are sure about your diagnosis, okay? Good. So this is the first part out of the way, okay? Let's talk about atrial flutter now. Now, this is why I wanted you to remember that atrial fibrillation is irregularly irregular, because atrial flutter is irregularly P waves with regular atrial activity, okay? So we will separate this into blocked and unblocked atrial flutter. Blocked atrial flutter means that the AV node allows every second or third P wave to form a QRS. So the atria will fire 3 times, and the AV node will only allow one out of those 3 impulses at a fixed rate to pass to the ventricles. Okay, does this make sense? So every time you might have 2 P waves and then 1 QRS. And you will see this because it will look like a fork. We call those F waves, okay? This is what it looks like. Can you see here? F waves. Why? 1, 2, 3, QRS. 1, 2, 3, QRS. And this is constant, V2 here, okay? 1, 2, 3, QRS. This means that this is a fixed rate of 3 to 1, okay? And this is very important because mostly it changes the fibrillation, which is a very severe problem for patients. And because it may cause hemodynamic collapse if there is a constant firing of 1 QRS, 1 P, 1 QRS, 1 P. If we have atrial flutter, it is very important to separate between blocked and unblocked. Does everyone understand why this is regular? Why this is irregularly irregular? Does everyone get this? Because the same pathology occurs constantly, but it's not normal. Okay, the other one is all over the place. Atrial fibrillation is all over the place. Atrial flutter is usually fixed. Does everyone understand the difference? Thank you for this addition. And this is the part we care about, okay? Fibrillation V flutter, the P wave, okay? And the QRS pattern. You see, the QRS here is broad, but the distance between the QRSs is the same. Here, it isn't. So the rhythm is irregular. And those are regular because they're the same every time. So regularly irregular and irregularly irregular. Here, carry on. I really need you to understand this. This is a question you will get from the 3rd year all the way up to the 6th year. Keep this slide, understand it, and understand that atrial flutter can actually become atrial fibrillation, okay? Are we clear to go on? Now the fun starts, actually. Everyone okay? Good. Let's talk about extrasystoles, okay? Now, what is an extrasystole, you ask? An extrasystole is when something, a beat of the heart that occurs outside the normal cardiac cycle before it's time for it to occur. And it can either be atrial or ventricular extrasystole, which makes sense because there's one part firing at the wrong time, okay? Now we will talk about the concept of compensatory pauses, which is necessary in order to determine the origin of the extrasystoles, okay? A compensatory pause will occur when there's a pause after an extrasystole, and the pause is long enough to compensate for the prematurity of the extrasystole. And this probably means nothing to you because you cannot see it. Yet here we are, okay? Now, I need you guys to stay with me here. We will talk about compensatory pause. This strip right here, has a complete compensatory pause. Why, you ask? Because for compensatory pause to occur, you need the addition of those two, so the distance from here and here and here, to be the same with this place here. Okay? Because that means that the heart had the complete amount of time it was necessary in order to recover from this extra systole. Okay, can anybody guess, based on what we said right here, on the top strip, where the extra systole occurs? Can anyone guess where the extra systole occurs? Oh my mouse is really not cooperating at the moment. Just turn on your mics until I fix my... Someone turn on the mic that is sure. On the top part, where do you see an extra systole occurring?
The third one.
The third one, yes. And is it atrial or ventricular?
It's ventricular.
Why? Can you tell me why?
Because the QRS complex has the problem.
Yes, that is correct. I don't know who you are, but great job. I can actually see you. Can you tell me your name? Yeah, can you tell me your name?
Isaac.
Isaac, great. You're correct. Yeah, you're right. So the problem is here, and keep in mind that you need this because ventricular extrasystoles have complete compensatory pause. It's that simple. On the contrary, here you see an extrasystole firing right here on the bottom. This affects the P wave, so that means that, correct, I just saw the chat, you were all right, that there's a problem with an atrial extrasystole that will occur right here, and the compensatory pause is incomplete. Why? Because those distance is not the same as those two here. Does this make sense, or should I say it again? If anyone has a question, they might as well ask now.
Could you just repeat it one more time, please?
Yeah, of course, John, I will. Good. So, as you see here, the distance, in order for an extrasystole to have a complete compensatory pause, the distance of two consecutive beats has to be the same. Does this make sense? Because that means that the ventricles had time to rest after this extrasystole took place. Do you understand that?
Yes.
On the bottom one, the compensatory pause is not complete. Why? Because if you measure like it is measured here, the amount of time that has passed is not the same between two consecutive beats. Does this make sense?
Yes, much more, thank you.
Okay. So you need to measure this every time you see an extrasystole. Do you also understand why the one on the top is a ventricular and the other one is a atrial extrasystole? Jonah, do you understand why?
Sorry, I texted. Yes, I understood. Because P wave is related to atrial repolarization. Depolarization, sorry. And the QRS is for ventricular one.
Correct. Okay. So the mechanism. This is mostly for third year students. Okay. You need to explain why extrasystoles occur. Okay. Automaticity, reentry circuits, and triggered activity. You say, what the hell is this? Okay, automaticity. We said that depolarization is the principal event of the cardiac cycle, okay? So this is when depolarization occurs in a non-nodal tissue leading to one extrasystole, okay? So a random place that shouldn't fire is firing. Why does this occur? Electrolyte abnormalities or ischemic myocardium. Re-entry circuits. This is usually associated with some anatomical abnormalities, but it also occurs in infarcted myocardium, and I really hope this makes sense. Infarcted myocardium means that there is inadequate oxygen supply, okay? Now, this tissue that is infarcted is usually slower conductingly because the cells don't operate normally. They have lower oxygen, they work slowly. So let's take, for example, that there is tissue here, and this part in the middle here is infarcted, okay? As the impulse travels slowly and descends, it will go faster via the normal tissue and much more slowly in the ischemic part. So that means that after it's finished on the parts that are healthy, then it will arrive to the remaining parts from the ischemic part of the myocardium. Do you understand? And it will re-trigger the same parts that had already been depolarized by the previous wave of depolarization in the healthy tissue. Does this make sense? This was a bit tough. Does it make sense? Philippa? Yes. Joanna? Good. Philippa?
Yes, yes.
Good. Okay. So, let's go back. Okay. Last but not least, triggered activity. We have a preceding impulse that leads to a premature activation that leads to a threshold, reaching it, causing an extrasystole. So that means that a part that isn't usually depolarized is hit with multiple impulses, and even though it usually does not contract, it starts contracting because there is a lot of impulses going to it. I think this is the simplest of the three to understand. Let's go through atrial extrasystoles. Okay, so systole, extrasystole, and as you see here, there is incomplete incompensatory pause because this difference here is not the same as this one. Okay, so this is what we talked about before. Atrial extrasystole will occur anywhere in the atria, and as we said, there is an aberrant P wave because the P wave is representative of what happens in the atria with depolarization. Do we understand that? Good. Now, from this slide is actually a bit tough. You need this part and this one. Atrial extrasystole. Okay. P wave before a QRS because there is a problem occurring in the atria and they start firing at random, and there's a non-compensatory pause. So there will be a shorter difference between two consecutive cardiac cycles. Okay. Yes, tell me. Who is this? Nothing. Okay. Multifocal atrial tachycardia. This sounds like a lot of gibberish, but if we go through every single word one by one, we will manage to understand it, okay? Multifocal means that there are multiple places firing at the same time. Where are those places? In the atria. And tachycardia means that the heart is firing faster, as we said, with a rate of more than 100. Can anyone guess how this will show on an ECG strip? Anyone want to take the time to talk?
Close together.
How?
Close together.
Close together, possibly, but there are three different places firing at the same time. So what do we need to see? Multiple P waves. Why? Because there are multiple places in the atria that are firing. Does this make sense? Probably. And there are different shapes of P waves. And now you ask me why? Because this is multifocal. So when one lead takes the same picture of the atrium, it sees different parts of the atrium firing. So the waves cannot be the same since there's a different part of the atrium firing. Does this make sense? They fire really rapidly and they fire from multiple points. Does anyone have a question with this? Every entry tachycardia. This will be one of the final slides for today. I hope I didn't confuse you a lot with all that happened. Okay.
I'm sorry, could I ask one thing? Is the multifocal atrial tachycardia
Who is
related?
this?
Angelo.
Who am I talking to? Angelo, how are you, mate? Good, tell me.
Nice, thanks. Anyway, I'm asking, is this multifocal atrial tachycardia related some kind with the lung disease? Like,
Yes, it is. And
because
it
in the
what you
corona
see here,
with some pulmonaritis.
COPD, hypoxia, and pulmonary hypertension. Okay,
Okay,
this is
thank
what you need to keep in mind. Pulmonary hypertension, which means that there's a high pressure. Pulmonary hypertension means the high pressure in the pulmonary vessels. Hypoxia means that there is a presence of low oxygen in the lungs. And COPD means that there's a chronic obstructive pulmonary disease. This actually dysregulates the atria because if you think about it, the right heart is connected to the lungs. And I think it makes sense. If there's a problem with the lungs, there's a problem with the right heart, they start firing at random, you see multiple P wave morphologies, okay?
Yeah, understood.
Okay.
Here.
So let's talk about AV-oriented tachycardia, okay? Now, this is something, and it will be the last thing I will talk to you about today, that is very common, and it's very common in exams to be asked, okay? We have something called the pre-excitation syndrome associated with an accessory pathway. And you're like, what do you mean? Pre-excitation means that there's something happening before the normal excitation, okay? And accessory pathway means that there is an alternative path for the electricity and the conduction to pass between the atria and the ventricles, except the normal conduction system of the heart. And this will represent with something that we call a delta wave, because there is early depolarization of the accessory pathway. So can someone type in the comments, since we will have a problem that starts with firing at the ventricles faster, where will the delta wave present? Will it present at the P wave or will it present at the QRS? There will be pre-excitation of the ventricles. So where will this show?
P wave.
It will not show at the P wave because it starts at the atria, but passes faster to the ventricles. So the Wolff-Parkinson-White is a pathology of the atria that presents in the ventricles. Do we understand why? Because this is a normal P wave, okay? But this is not a normal QRS. You can see the QRS starts faster than it should. Can you see it here? This is a delta wave. This here is the delta wave. Let me draw it. This here is the delta wave. This shouldn't occur in a QRS. Do you understand it? There is an impulse going from the atria to the ventricles faster, okay? And it starts the QRS faster. Why? Because the ventricles start contracting earlier. Does this make sense? Guys, that answered the P wave. Oh my, this is a mess. Good. So, take this off. Actually, those people don't necessarily have a impaired cardiac output because it's usually mild. So Wolff-Parkinson-White patients present, and we find this asymptomatically, mostly in young patients. So when you find this asymptomatically, and there's no problem with the cardiac output, you do an ablation, and you actually disable the pathway that is the accessory pathway, Lucas. So the pathway returns to normal before they usually start to present with problems with their cardiac output, because you can see this on an ECG. For example, here, it's very, very, very easy to see that there's something going wrong with a wider QRS, with the presence of delta wave and a shorter PR interval. Shorter PR interval, we said it's the time between the firing of the atria and the ventricles, correct? So if there's a pre-excitation and the ventricles start firing faster, the PR interval will be shorter, no? I think it's pretty self-explanatory. No. Junctional rhythm. This is mostly for 6-year students, I think, It's very hard to see in the years below, maybe for propaedutics of internal as well. Okay, how does this happen? An junctional rhythm will occur when there is a problem with the SA node firing. So the AV node, the lower parts of the heart actually will start firing fast on their own, despite the SA node firing badly or not firing at all, right? There might be a pathology, might be cut, might be traumatized from surgery, from ablations. You know, mistakes happen and some people are more unlucky than others, right? So the AV junctional regions, so the regions around the AV node in the heart conductive system start to take over and they fire as the principal pacemaker of the heart, okay? So, as you see, we have an active and a passive nodal rhythm, and this rhythm can actually hide conditions like sick sinus syndrome because the junctional regions will take over and they will fire instead of a sick SA node. I hope you understand this. The heart realizes that the AC node is not working, so the junctional regions of the AV node start firing instead of it, okay? Good. We will separate the superior, middle, and lower nodal rhythms. And what we said we will look for rhythm, yes, the P wave. And the morphology of the P wave will be the one to indicate where in the nodal region we will have the new node firing, okay? If it's superior, we will have a negative P wave in lead 2 and 3, actually 3, and lead 2. Lead 2 is the one you will look for with a negative P wave. It makes sense that the P wave will be negative. Why? Because the placement, the anatomical placement of the node that is firing, when it's taking a picture of in the ECG, will be lower than the normal place where you will have it in the SA node. It makes sense if you think that the SA node is high up in the right atrium, and now in the junctional area they start firing around the AV node, it's normal that the P wave will be negative, okay? So those are around the area of the coronary sinus, and then we have the middle and the lower nodal rhythm. The middle nodal rhythm will actually not present a P wave because it will be inside the QRS. So no presence of QRS, boom, middle nodal rhythm. And the lower nodal rhythm is when we have a P wave that is negative and after the QRS, okay? But this will make easy sense when I show you. So negative P wave, I hope everyone sees it. QRS, T wave, negative P wave. QRS, T wave, okay? No P wave, no P wave, no P wave, no P wave. So superior, middle, and inferior. Why? Because you can see the P wave here. It is after the QRS and it's before the T wave, in between the QRS and the T wave. Does everyone understand this? Does anyone have any questions? Guys, does everyone understand this? This will have a rhythm between 40 to 60, so it's usually slower, okay? But keep in mind that looking for the P wave in leads 2 will be enough to diagnose this condition, okay? Look at its relation between the QRS and the P wave. And last but not least, and at least I think, yes, last but not least, will be the supraventricular paroxysmal tachycardia. Again, a sound of gibberish, but if you take it one by one, it makes sense. Supraventricular. What does it mean, supraventricular? We said that an arrhythmia that is supraventricular will present with a narrow QRS, okay? Tachycardia will mean that the rate is more than 100, and you can see here the rate is crazy fast. It's around, can anyone tell me how much it is? Let's not forget our roots. It's around 1.5, so, you know. Yeah, right about there, Mary. It's actually right about there, okay? So it fires at a very big rate with narrow QRSs, supraventricular, and paroxysmal, because they usually occur after an extra systole. You will have an extra systole, supraventricular one, so an atrial one, an abnormal beat with an abnormal P wave and a QRS with an incomplete incompensatory pause, and then this will occur. It's chaos. It happens fairly, it's regular, and it fires at a very fast pace. Can anyone tell me, I know this is for the next lecture, but can anyone guess what a difference the ventricular paroxysmal tachycardia will have? How will you be able to differentiate a supraventricular and a ventricular paroxysmal tachycardia? Where will I see the difference? Will I see it in the P wave, in the QRS, or in the T wave? Because paroxysmal, it will stay, yes, a wider QRS, correct. Because it will fire abnormally in the QRS. Great job, Lucas. And I think this will be the end of the first two lectures we're going to do together on ECG. I'd like to thank you all for your attention. It's a very big pleasure for me to see that the number of participants was constant during the lecture. That means you were all involved. And stay tuned so we don't get things like this in clinical practice in part 2. And if there are any questions you would like to ask, I'm here to listen. If everyone, there's something someone didn't understand.
I have a question, sorry.
Yes.
When you spoke about the atrial flutter, you said there was 2 types, blocked and then blocked.
Yes.
Could you explain the difference again or show us like an example of unblocked, please?
Yes. So blocked and unblocked. You're all very welcome and thank you for listening, by the way. So blocked and unblocked. Give me a second. This is blocked. Who am I talking to?
Hear me? My internet is bad.
Who are you? I can't hear you. Don't be shy. It's okay. Tell me who you are.
No, my internet is bad.
Okay.
Sorry.
The difference between blocked and unblocked rate is that the number of P waves in a blocked atrial flutter will always be the same. Okay, so there are always 3 P waves before 1 QRS here. Okay, do you see it?
Yeah.
This is a fork. It's 3 to 1 blocked. If it was 2 to 1 blocked, there would be 2 P waves and 1 corresponding QRS. Does this make sense?
Yeah, my doubt was more related to the blocked one, because you said it would be a ratio from 1 to 1.
This is blocked. This is blocked. If it is unblocked,
yeah.
Okay, there will be 3 P waves here, 1 QRS, 2 P waves here, 1 QRS, 4 P waves here, 1 QRS. So the number of P waves will not be constant. This is the difference between blocked and unblocked. Okay? This makes sense?
Yeah, like good. I had the doubt because there it was written 1-to-1 ratio and I didn't.
The 1-to-1 ratio is the most dangerous one because that means that the patient is hemodynamically unstable. So 1 P wave, 1 QRS, but pathological. Okay?
Okay, thank you.
Any questions?
I have one, and the last one, of course. Does in Wolff-Parkinson syndrome, do we always find it as accidental finding, or which main symptoms does the patient complains?
Actually, if you think about what
because you said usually the patients are asymptomatic, that's why that was my doubt.
If there is a severe problem with Wolff-Parkinson-White, you will see that the patient fatigues very easily. Why? Because the heart is not firing as it should. Right? You understand what I mean? The heart is tired of not firing properly at the rate it should. The atria, actually the ventricles are tired from firing too quickly. Then it will start to be symptomatic with syncope and angina and breathlessness and tiredness while exercising and so on and so forth.
All right, thank you very much. It was really interesting.
You're welcome. Anyone have any more questions?
I've got one question, if it is possible.
Yes, who are you?
I'm Isaac.
Hi again.
Hi again. I was wondering to see the slide about the 10 rules or 10 basics of the ECG.
Yes, please.
Okay.
Give me a second. There you go.
Yeah, here it is. My point is about the S wave. It is written the S wave must grow from V1 to V3.
Yes. So you will see it progressively getting bigger.
It means in V1 it is smaller, and then in V3 it gets deeper.
In V1 it's big, then it gets bigger and taller.
So in V3 is the deepest.
Yes, this is what it means. Yes. Correct. And it's all because it's a matter of perspective of the patches in the heart, you know, and how the signal, how the depolarization is conducted.
Okay.
Okay, sure.
Thank you.
Take care.
Yeah.
You're welcome. Guys, if there are no more questions, I'd like to thank you for your attention. And I'd really hope to see you again on Wednesday, where the lecture will be faster and more interesting, and it will be more clinically oriented. But I'd really like to make sure that you understood the basics and that you can apply them in order to use them in your exams and your clinical practice, okay? I hope it helped, and take good care, okay?
Thank you.
Take care.
Thank you.
Bye-bye.
Thanks.
Bye.
Wait, Georgina needs to speak.
It's okay. Thank you guys for being here. We hope to see you in the next webinar. And whoever wants can fill out the feedback form in order to get the certification also. So Sotirios, thank you.
It was a pleasure.
You did a great job. The pleasure is ours.
I hope it helped.
It did, I think, like at least from me.
Okay, please fill in the form so we can make this a core elective from next year, and anyone who needs help will be able to do it in person, okay?
I'm sending it in the chat again, Anton. That's the form.
Okay, guys, we'll add it on Facebook as well, so you can fill it there.